Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. For the next few podcasts, we have something pretty special for you. With our 10th anniversary of the organisation, we held a panel discussion with some really great speakers. So over the next few podcasts, you will hear the highlights of our 1010 Pathology Technology Disruptors Past and Future. Enjoy part one and listen out for the next podcast when it comes out. As you can tell, I started in this business a long time ago, although this is a sort of a joke photo, sort of is a giveaway. But in the lab that I worked when I first started, we did a business a lot like this. We did urea proteins by the Kaldale method. Anyone? No? Good. And it drew me to the lab. I loved the science. I loved the research. I loved the ability to be able to impact people's health. My first job was actually an NH&MRC grant recipient to measure insulin and C-peptide on the Bustleton survey population. And that was before there were any kits for insulin and C-peptide. It took me all year to do about 800 insulins and C-peptides. Today, you could do that workload in one of our larger labs in probably 6 hours. So today's panel discussion, we want to explore the factors that led to that kind of efficiency dividend that our industry has delivered. We want to look at how demands on healthcare of the future will change over the next few years and how that will affect what we do. And we'll spend some time to speculate on how we might be able to meet that increase in demand, while at the same time delivering the highest quality, accessible and affordable healthcare services in Australia. So ladies and gentlemen, welcome to the Pathology Technology Australia 10th anniversary panel discussion, Pathology Technology Disruptors Past and Future. And of course, it wouldn't be a panel discussion without a panel, so I'd like to invite our panel up. Firstly, Adjunct Professor John Skerritt. John, would you like to come and join us? Thank you very much. John's the Deputy Secretary for Health Products Regulation, Department of Health, also Adjunct Professor at the Universities of Queensland and Canberra. Secondly, Professor Frank Bowling. Frank, would you like to come up? Frank is Professor, is Director of Pathology, Melbourne Health, and Professorial Fellow at the University of Melbourne. Also, importantly, member of the Department of Health's National Pathology Accreditation Advisory Council, NPAC. Welcome, Frank. Dr. Mukesh Haikerwal, AC. Very happy to have you here, Mukesh. And Mukesh runs a general practice surgery, one of the few in Australia with an APP.
One of five. One of five.
One of five in Australia with an APP. Now, I'm going to read a little bit about Mukesh because he's a really special guy. And you can look up on him later. And at the risk of embarrassing him, he's also the chair of the National Doctors Mental Health Program. And there are some very good reasons for that. Look it up. He's also the chair of the Australian Institute of Health and Welfare, the director of the Cancer Council of Victoria, and formerly president of the AMA. So we're very happy to have you here, Mukesh. Dr. Coleman Taylor. Where are you, Coleman? Thank you. Dr. Coleman Taylor. Coleman is owner, operator and director of Health Technology Analysts, a health economics firm. And he's the co-joint senior lecturer at the University of New South Wales and postdoctoral research fellow at the George Institute for Global Health. Welcome. Mr. Colin Denver. Where's Colin? Yep. So, Colin's the CEO at SpeedDX, and there's a special reason for having Colin up, and that'll become apparent later. But previously headed up sales in APAC for Meridian Biosciences, and before that launched BioLine in Australia. Colin, you're a science graduate, but also with a postgraduate in management. So thank you and welcome. And last but by no means least, am I up to the, yep, Dr. Megan Keeney. Megan, formerly a medical practitioner in emergency medicine, but currently medical advisor to the Technology Assessment and Access Division, Department of Health, and formerly medical advisor to the TGA. So, John and Megan, you're sitting at opposite ends of the table now. Sorry.
John was never my boss.
I'd also like to, we also have some special guests in the audience, and we'll get to those later as the questions develop. And we also have our wonderful members here, and I really appreciate you coming along. We've also invited some potential members, so make sure you get around them as the networking event goes on. So, the format of today's proceedings. What will happen is I'll put a proposition, and then we'll get the panellists to expand on that proposition a little bit. Maybe we'll have some good discussion backwards and forwards. We'll also get some positions from the audience as well. So let's kick it off. In the past 10, 15, maybe 20 years, we've seen substantial development in the range of pathology tests and services offered. The number of tests has increased dramatically. The turnaround time has decreased. The quality has improved. When I started in labs, there were, I think, about 1,200 registered labs, maybe a few more. Today, there are less than 800. Most of these fall under either 3 of the main pathology providers, private pathology providers, or the 7 state and territory providers. So they coalesce under major management and buying groups. In part 1, we'll look at the factors which led to quite a significant efficiency dividend given by this industry to the healthcare, to pathology over the past 15 to 20 years. So just a preamble of diagnostics. I mean, IVD testing covers that entire continuum of health, from preconception to post-mortem. It covers all of the Ps, yeah? And we know that around 70% of pathology testing is used, about 70% of the medical decision-making and management decisions are made using pathology, and 100% of all cancers are diagnosed using pathology. Yet, we have maybe just 2.7% of the total Medicare spend at the moment, or healthcare spend, in fact. Those numbers are hard to dig out, but that's where we probably are. What's possibly more startling is that there's probably around 500 million tests performed in Australia each year, either in hospital labs, in large private pathology, in community setting, or self-testing. We think, but we don't know for sure, about 35% of those are funded through Medicare benefits schedule. But we don't really know. And in fact, something that probably should concern us a great deal if we're thinking about the healthcare economy is that we actually don't know how many tests are done, nor do we have an integrated picture of what tests are done, when they're done, why they're done, on whom they're done, and what the outcome is. Another observation made by Graham Collins in 2016, which is the picture on your right, is related to the growth of pathology testing versus the reimbursement. So from the Medicare data, we know that pathology testing increased about 3.5% year on year for the past 15 years, while at the same time Medicare expenses increased 4.2%, approximately 128% growth over that time. Now that's the total Medicare spend, it's not the pathology part of that. Pathology, I don't have exactly what that pathology was, but many like to think, especially in this industry, many like to think that that lagged somewhat behind. What is probably important is when we look at average weekly earnings and CPI, they seem to go up at a much faster rate than the Medicare spend did. Around 294% for weekly earnings and about 185% for CPI. So it's highly likely, and in fact it's pretty obvious, that the pathology industry as a group, that is the laboratories, the suppliers and everybody else involved, absorbed a significant amount of that cost and in materials, in time, in labour, and in fact delivered a substantial efficiency dividend during that time. So let's turn to the panel. I'd like to maybe go to Frank first. Frank, you had experience at both the Mater and at the Royal Melbourne. What were the main factors contributing to your efficiency gains over the last 10, 15 years or so?
Thanks, Dean. You've sort of inferred it already. The gains clearly came from automation within laboratories, standardisation of testing, and essentially multiplexed type technologies. So the gains definitely came from technology. There was a lesser gain, which probably wasn't fully realised within Australia, also because of informatics. And I think the laboratory information systems in Australia are not as good as they should be, but there was still definitely a gain from informatics. So automation informatics, I'll just finish by saying though, that gain has tended to flatten. So I think we've achieved what we'll achieve there, unless there's a complete different paradigm about the testing. And I'll take up just 1 second of your time. Some of the new technologies that I've seen that haven't been implemented in Australia yet, 300 infectious organisms on one chip, PCR reactions accelerated. You can complete the whole PCR now in 2 minutes. Then you have to ask the question, do you really need a laboratory?
Let's look, that's perfect, but let's keep that powder dry for later. Perfect, thank you. Let's go, that was very good. Coleman, as a health economist, you might have evaluated maybe this efficiency gain, I'm not sure. From an economic perspective though, what have been the efficiencies delivered to the system, and is there any way of quantitating that?
Well, I guess the short answer is we don't know, but what you would take from this graph is that there has been substantial efficiency gains relative to the services. So the inputs have decreased in terms of the Medicare rebates, and the services have gone up. So inputs relative to outputs, your efficiencies have improved. But I guess as a health economist, what you want to know is the inputs relative to the outputs in terms of patient outcomes.
Okay, maybe somebody in the audience, I know Scott Jansen, you're here, and you've been in and around laboratories for a long time. You're currently Clinical Streams Coordinator at New South Wales Health Pathology. But from your experience in the past, 15, 20 years, what has been the main contribution that's meant that you can meet the demand in the services you've been offering?
I think Frank mentioned those earlier. They are to do with the technology, advances in technology with automation. We've seen that stemming from the 1980s, 90s in chemistry, immunoassay testing, haematology, coagulation. We're starting to see that more now in micro and immunology services. So there's been a significant advance in technology, and linking that to specimen transport, it reduces the manual processing steps. Certainly also IT. I think, and again I agree with Frank, we have developed IT considerably, but we are a long way to go in terms of getting the full advantage of that. But in your basic machine interfacing, having those results transferred, even as Mukesh mentioned before, the results heading back out to the GPs, a lot of that's automated these days. Third area, I know it's been touched on, is laboratory consolidation. That's occurred in a couple of ways. Certainly, if I looked at this in the private sector, you've had consolidation not only of practices but of laboratories to the larger, higher throughput type laboratories. In the public sector, we've seen consolidation of the state-based services in most states. Not the same level of consolidation in terms of laboratories, because we're dealing with a different population. If I use the example of New South Wales, we have around 8 million people, run about 200 public hospitals. Within New South Wales Health Pathology, we still run 61 on-site laboratories. That is there to meet the acute care needs of those services. We've been able to introduce other technology like point of care at a number of places to supplement that testing, but that's been our benefit and the benefit so far.
Thank you for that. That's very comprehensive. So I think that really then picks up on where I saw the situation myself. Around 65% of the efficiency is being generated out of technology, of what we do as members of this community. And about 35% is lab generated, and it comes out of things like Scott was just mentioning, consolidation, some improvement in processes, some IT that's been brought into it. That ends part one of our special podcast series. And really that looked at how we've created the efficiencies in laboratories up until now. Listen out for part two, where we start to explore some of the challenges we're going to face in delivering the healthcare outcomes we want in the future. Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series, or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.